Welcome everybody to the second episode of Snooze TV. We are broadcasting live at this point, and I want to welcome you all to our second episode. This episode is going to be all about idiopathic hypersomnia, and we have a wonderful guest panel to introduce you to in just a moment. But I just want to introduce you to myself first. My name is Jennifer Beard. I'm with the Hypersomnia Foundation. I am the host of Snooze TV. And this show is going to be very highly interactive. We encourage you to pose questions to our guest panel members throughout the show. You may be watching this show on our Hypersomnia Foundation website, located at www.hypersomniafoundation.org. If that's the case and you decide that you'd like to pose a question to one of our guest panelists, then you can scroll down to the bottom of... Welcome everybody to the second episode of Snooze TV. We are broadcasting live at this point, and I want to welcome you all to our second episode. Oops. Sorry about that. I had one of those windows open. So all you have to do is scroll down to the very bottom of our website and click on one of our social media icons, either our Google Plus or our YouTube channel icon, and you can go over to either of those pages, and beneath the broadcast window in the comment area, you can type your question in as a comment, and we will be able to pull your comment on screen and answer your question live on the air. So please feel free to interact with us today. We want this show to be interactive, and we want you to pose your questions to our guest panel members. So as I said, tonight's topic is all about idiopathic hypersomnia. So as you're getting ready to post your questions, I just have a few tips for the audience members. So I'm going to try to share my screen. Let's see if this works. Let me do a screen share here. Okay, can everybody see my screen?
I can see it.
Okay, great. So my 5 tips for the audience are: when you type in your questions, to keep your questions succinct. We can only see so many characters that you type on our screen at a time. So in order for the audience to be able to see your questions, just try to keep them succinct and limit your characters. Please keep your questions general. We do have Dr. Plant with us tonight, a member of our medical advisory board, but we're not going to be able to give medical advice out for your specific situation. So if you try to keep your question general, it'll be much easier for our guest panel members to be able to respond to that. Please post questions you think would be helpful for the audience to know the answer to. So if we're chatting about something that you understand, but you think not everybody in the audience might understand it, and you think that it would be helpful for the audience to have...
I can't hear you.
I can hear for me.
Yeah. That as well. And just be aware that your comment or question may appear on the screen. We have that up and running this evening, so be aware that that might be a possibility, that your comment or question appears on screen. Okay, I'm going to try to stop sharing my screen now. Let's see.
Yay!
Am I back?
You're back.
Yep.
Okay, great. Okay, so that's how you participate in our show this evening, and we look forward to seeing some of your questions. Just a reminder, this show airs the second Friday of every month at 8 p.m. Eastern Standard Time. And I'm going to go ahead and introduce the guest panel members down at the bottom of your screen at this time. So, Fabi, if you'd be kind enough to white box Dr. Plant for us, please.
All right.
I don't see him in the big screen.
He's not showing up. He's showing up on mine. Let's
I am
see.
here.
Oh. No.
Okay, we're back. Is everyone here? Let's see. Everyone's here, and I see Dr. Plant in the big window. Excellent. Okay, so this is Dr. David Plant. He is the Assistant Professor of Psychiatry at the University of Wisconsin School of Medicine and Public Health. He is a Fellow of the American Academy of Sleep Medicine, a member of the Sleep Research Society, and Program Director for the University of Wisconsin Sleep Medicine Fellowship. His current research uses high-density EEG to study sleep and wakefulness in hypersomnia and affective disorders. Welcome to the show, Dr. Plant. We appreciate you being here.
Thank you for having me.
Okay, so we're going to introduce Sarah Nichols next. Let's see. Perfect. Okay, so Sarah has always been sleepy, but it was not enough to disrupt her daily activity until the fall of 2013. Since she works from home most days, she was able to hide her naps until she was diagnosed with idiopathic hypersomnia in February of 2014. Since then, she has been working to find the right medication and sleep schedule to keep her comfortable and awake. Her husband seems to have figured out that life is easier when her bedtime is 9:30, and he's also figured out that the more sleepy she gets, the fewer nouns she uses. That's interesting. Welcome to the show, Sarah. We appreciate you being here.
Thanks, Jen.
Our next guest panel member is Alex Hale. Okay. Alex is finishing his senior year in high school in Atlanta, Georgia. He plans to start next fall at LM University with an interest in communications. He was originally diagnosed as having idiopathic hypersomnia about 1.5 years ago during his junior year, but had been noticing symptoms for at least the year prior to that. Welcome to the show, Alex.
Thanks for having me.
And then we have Jenni Murray. Okay. Jenni is a 25-year-old college student who has been asleep for most of her life. Jenni has been noticeably sleepy since birth and has always averaged at least 16 hours of sleep a night, but up to 86 hours at a time.
Wow.
She was finally diagnosed in 2013 with non-24-hour sleep-wake cycle and later hypersomnia. She also has Ehlers-Danlos syndrome, a genetic connective tissue disease that greatly affects her life. Welcome to the show, Jenni. Thank you for being here.
Thank you for having me.
And last but not least, we have our fabulous technical producer, Fabina Lopez, who is also the proctor from the MPA program at Clemson University. She's going to be here making sure we don't have too many technical difficulties tonight, which is quite a massive job.
I'll do my best.
For Michael's for race tonight at short notice. So thank you so much, Fabi. We do appreciate you being here.
Thank you.
Okay, so I just, let me unwhite box you. So I thought that since we're talking about idiopathic hypersomnia tonight, Dr. Plant, I wonder if you'd be willing to go over some of the diagnostic criteria for idiopathic hypersomnia so that everyone in our audience and all of the guest panel members are clear about what we're talking about tonight.
Certainly, I'd be glad to. So idiopathic hypersomnia is a central nervous system disorder of excessive sleepiness. So the most important symptom that everyone with idiopathic hypersomnia is going to have is some degree of daytime sleepiness. So people will either endorse an irrepressible need to sleep during the day or lapses into sleep during the day. The diagnostic criterion for the disorder, really, there's a number of different methods that we can use, but most people in sleep medicine use something called the International Classification of Sleep Disorders, or ICSD, which is now in its 3rd edition. So in addition to having daytime sleepiness, which has to be present for at least 3 months, according to the diagnostic criteria, but usually in most patients have been there far longer. You also have to have a few other characteristic signs and symptoms as well as some objective findings. What I mean by that is in sleep medicine we use things like polysomnography, which is a sleep study, as well as something called a multiple sleep latency test, or MSLT. What that is it's a nap study that measures how quickly people fall asleep. So according to the ICSD, you really do have to have an objective finding of either excessive sleepiness in terms of falling asleep quickly on naps during this MSLT or nap study, or prolonged total sleep time with a complaint of daytime sleepiness. So specifically, on the multiple sleep latency test, people fall asleep in a pathologic amount of time, which is typically less than 8 minutes on average, over across several nap opportunities throughout the day. Also, one of the things that differentiates idiopathic hypersomnia from narcolepsy, which is another common sleep disorder or central nervous system disorder of excessive sleepiness, is that people with idiopathic hypersomnia do not typically go into REM sleep early during the course of their naps. So according to the diagnostic criteria, you have to have fewer than 2 REM episodes during these naps on testing. As an alternative to the multiple sleep latency test, there are people with idiopathic hypersomnia who do not have a short sleep latency. In other words, they don't fall asleep quickly on their naps. That doesn't mean that they don't have idiopathic hypersomnia. What it means is probably that the multiple sleep latency test is not the best test for diagnosing or characterizing their problem. So recently, when the ICSD was updated, it also included the complaint of, or the problem of excessive total sleep time. So according to the ICSD-3 now, you can also be diagnosed with idiopathic hypersomnia if you have a complaint of excessive sleepiness, as well as a long sleep time documented by either an extended sleep study, so meaning people have a sleep study where they're allowed to sleep basically as long as they normally would for a full 24-hour period, and if it shows that people are sleeping more than 11 hours, even if you've corrected for sort of chronic sleep deprivation, which can cause that as well, that can give you a diagnosis of idiopathic hypersomnia. Or if you follow people longitudinally, sort of out of the testing center with something called an actigraph, which is a wrist-worn device that measures rest activity patterns. And again, if people are sleeping more than 11 hours per day on average and are also excessively sleepy, that too can be used to make the diagnosis of idiopathic hypersomnia. The reality, though, Jennifer, is actually the diagnosis of idiopathic hypersomnia in a lot of people can be quite difficult. So even though we have these objective measures in place that try to give us an idea of how we can diagnose people, there are certainly people who aren't going to meet some of these objective criteria. In other words, they aren't necessarily pathologically sleepy on the multiple sleep latency test, and they're not necessarily sleeping 11 hours either in the sleep lab or at home. In that case, actually, the latest version of the International Classification of Sleep Disorders gives the clinician a little bit of wiggle room as well, sort of recognizing the fact that there are going to be people who certainly have a clinically significant problem with excessive sleepiness and or excessive total sleep time, and it's sort of in the clinician's judgment at that point in time if they think someone has idiopathic hypersomnia.
Thank you, Dr. Plant. That's very, very helpful information. Just to take a quick poll, everybody on the guest panel, how many of you have had an MSLT, at least one? Alex has. Jenny has. Sarah, have you had an MSLT? Sarah has. Have you guys had more than one or just one?
Just one.
I've had 2.
You've had 2, Jenny. Sarah? I think you're muted, Sarah. Just one? Okay. Okay. Yeah. In our non-scientific anecdotal poll, I just thought I would ask that of you guys really quickly. So I thought we might start kind of at the beginning of your journeys and your story and then kind of come to present day. So with that in mind, Alex, maybe you want to talk a little bit about, you know, when you noticed it all kind of started for you and what kinds of symptoms or signs you were noticing. Did you have anything in early childhood? Was it later in your life? So tell us about how your journey started, Alex.
Absolutely. Well, for me, it started absolutely in high school, probably my freshman year, and I was always a little bit tired, but I thought that was normal. I did a lot of activities, and I still do. I keep real busy, and I thought, well, I'm just tired from that. I did have the advantage. My mom was diagnosed with narcolepsy, so we were already kind of thinking that maybe it was related to that, or it might be narcolepsy itself. And you know, when I realized, okay, I'm falling asleep in half my classes, this is not good. I'm sleeping in the clinic once a week, or twice a week, or 3 times a week. I went to actually a pediatric pulmonologist, and that was where they arranged to have a sleep study done. And originally, it was actually I was diagnosed with narcolepsy, which didn't make sense to us because I didn't have cataplexy. I know you can have narcolepsy without it, but it didn't quite make sense. And that was actually when my mom met Dr. Rye at the narcolepsy conference, and I started seeing him. We did the the lumbar puncture, which confirmed idiopathic hypersomnia. He had the suspicion originally that that's what he thought it was, and that's where I've been.
Great, thank you for sharing that. Jenni, how about you? When did you notice that something just wasn't right? Have you always been really sleepy?
Yeah. So from birth, my mom was pretty concerned because I was sleeping a lot, even like as an infant. And if you ask her, I was the perfect baby because I was asleep all the time. But it kind of it started getting in the way of her having a life at that point because I couldn't. You know, she didn't want to wake me up and take me out because then I'd be really cranky, even like literally from birth. So she just let me sleep, and I'm the youngest, so that kind of got in the way of a lot of like plans growing up. But yeah, when I was school age, I would say it got worse. As I said before, I have difficulty falling asleep, but once I'm asleep, I will sleep forever. And I've also had multiple concussions, so they're not sure if that's at all related. But it started getting really bad in high school. I feel really bad, but I used to sleep on my drive to school every morning. It was a 45-minute drive, and I was the one driving. And so, like, I would just be woken up by the horns behind me at the stoplights, and I would sleep through my first 4 classes. I mean, someone would wake me up, I'd go to the next classroom, I'd fall asleep in class. And I had some teachers who were really understanding, and other teachers that were like, I'm going to fail you because you sleep in class, even though you do all your assignments. It's gotten in the way quite a bit, especially when my parents had me go to boarding school in the hopes that it would help me regulate my sleep cycle. That didn't work. And then when I got to college age, I mean, my mom's had to report me missing before because I fell asleep for like 2 days and they didn't know where I was. I've missed holidays. One time I woke up and I tried to eat and I got really sick and I was like, I don't know what's going on. And my older sister, who's also a doctor, was like, it's because your body went into starvation mode. You've been asleep for 4 days. So,
wow.
Yeah, it's always been a problem. I remember I did get the Actigraph used, and I remember the sleep doctor was like, oh, did you forget to wear this? I'm like, no, I was asleep. I was asleep for that long. So wow. It's always really been a problem.
And how about, thank you, Jenni. How about you, Sarah? When did you start to notice that something was wrong? Have you always been very sleepy since you were a young child?
Yeah, I've been sleepy my whole life, but just in the past few years, it's gotten so much worse. So in 2013 in the fall, that's when I went to the doctor, and I went to my primary care physician, and I lied to her. I told her I snored. And that's not true. I don't snore, but I knew that there was a problem, and I knew that she couldn't help me, that it was, you know, bigger than a primary care physician. So she sent me to a sleep doctor, and he diagnosed me.
So let's talk about, you know, your path once you kind of realized something was wrong, and all the doctors and tests that you had along the way, to the extent that you're comfortable disclosing that. Alex, I know you had mentioned that your first doctor was a pulmonologist, I think you said. Can you tell us a little bit about your journey with that?
Right. At the time, I was a minor. I was 17. I'm 18 now, or I guess I was 16 originally. And that was the best option for us. We talked to my primary doctor, and he actually originally gave some suggestions for me. I think I tried drinking cherry juice, something he'd suggested they thought would help or work, and then he referred us to the pulmonologist because a lot of sleep disorders are, I guess, based on apnea, and that's the doctor you'd see for that, and that's what they thought actually it was originally. Yes.
So in your MSLT, did it turn out that you didn't have apnea? Is that how?
Right, I had almost no apnea. It was very average, but I fell asleep. Well, I think one of them was in 90 seconds.
Wow.
And I was, sound asleep. I kept looking forward to the naps. So
Tell us about the MSLT, because it's not like you're in your bedroom at home where you're super comfortable, right?
No, not even close, not at all. And I think if I was in my room, it would have even been faster. I was at Children's Hospital in Atlanta. I was in a small room next to the coffee machine. It was on the other wall. I had a dozen different cables connected to my head, you know, all plugged in. I was plugged into the wall. I couldn't even roll over. I had to lay perfectly flat. And I thought to myself, falling asleep, and this was not the MSLT, but the overnight, the night prior, I thought, I'm not even going to fall asleep. They're going to think I'm the boy who cried wolf. I'm not going to sleep one wink, and they're going to say, you're fine. You're absolutely fine. That was my worst fear. Well, that didn't happen. I fell asleep, I think, the night before in 12 minutes, and the next day with the MSLT, I think it ranged from 90 seconds to 7 or 8 minutes.
Wow. And how about you, Jenni? What was the first type of doctor that you visited or that you went to or that you're seeking help?
I've seen a lot of doctors. So for this specific problem, I remember, like, you know, when I was younger, my mom would come with me to the doctors, and she'd be like, listen, I know sleep, like that's my job, and this is completely abnormal. She will fall asleep everywhere. She'll fall asleep in the shower. And no one really listened to her, but it wasn't until I talked to my primary care doctor and I finally kind of admitted that there was a problem, because I feel like, you know, when who wants to be like, oh yeah, I'm really sleepy, right? Because that people associate that with laziness, in my experience. So I'm like, yeah, I sleep a lot at inappropriate times and all of that. So the first doctor, I think it was through pulmonology, just because that's how a lot of hospitals have it set up, so that the sleep center is set up through there. But I got a study done before I had to have surgery to fix my nose, and they found I kind of snore sometimes. But then in like 2012, I went to a doctor, and she was like, yeah, you have no sleep cycle and you sleep a lot. So when they looked at the MSLT, I didn't realize I'd been asleep for some of it. I was like, yeah, I couldn't sleep at all. And they're like, you not only slept, but you had REM sleep. So like for all of those, like I fell asleep within like 1 to 2 minutes. So.
And Sarah, how about you? I know that you kind of have a unique insurance situation. I wonder if you might be willing to talk a little bit about that and your journey.
Well, yeah. I went to my health insurance is through Kaiser. So the primary care physician that I went to was a Kaiser doctor, and she was good enough to realize that I immediately needed to go to the sleep doctor, and that you know, that they could probably help me there. So I went to a sleep clinic that was not in Kaiser, and it was not a good experience. They, you know, when they immediately prescribed me stimulants, I didn't get to talk to the doctor. It just was a terrible experience. So then I started looking around and talking to people through the different Facebook groups. And I found out that a lot of people go through either pulmonologist or neurologist. So I went back to Kaiser, and I booked an appointment with a neurologist because I couldn't find one that said neurology, sleep, or something like that. So I went into the neurology department, and they said, well, you know, we have a sleep doctor. And I said, well, no, because I've been all over your website, and I haven't seen anything like that. And she said, yeah, this doctor is, you know, 20 miles down the road. And I said, well, sign me up. So I went to that doctor, and she was great. She said, okay, well, you don't have to go back to that sleep lab that you didn't like, and I'll be your doctor from here on out. And she's been great.
Are you all comfortable sharing what medications you're currently taking? Alex, I'll start with you.
Sure. Right now, I am working on figuring out the best way that flumazenil can work for me. I'm trying the lozenge and the cream, and I'm just trying to figure out timing-wise when it's best to take it, because being in high school, I change classes every hour. So the act of getting up and walking alone wakes you up a little bit. So it's hard to tell when do I want to take this. There is the delay between when you take it and when it takes effect. In the past, I've tried stimulants like Adderall. I've tried Nuvigil, bupropion, clarithromycin. I can't say that one. And none of those were proved to be particularly effective for me. Well, flumazenil has been, though, and but right now for me it's just trying to figure out the best way to use it.
Jenni, are you comfortable sharing your current medications and what you're taking for your treatment?
For sleep, right? I'm assuming you don't want the whole long list. Okay. I'm on flumazenil. I'm also on clonidine because I also have restless leg syndrome. I'm on Xyrem or sodium oxybate for sleep cycle regulation. It also helps with my hypersomnia. And I'm on Vyvanse, and I've been on pretty much every stimulant since they first came out with them.
Do you find that that those treatments are effective for you? Are they helping?
I definitely think they work.
I said, are they a work in progress?
I actually think, I mean, I ran out of my Xyrem. You never want to run out of your medicine. But other than that, I can actually like function. I can show up when I'm supposed to show up as far as like a sleep aspect goes. But yeah, altogether, it works really well.
And then, Sarah, are you comfortable sharing your treatment regimen currently?
Yeah, right now I'm doing clarithromycin, and it seems that it has been working for the past month and a half, and it seems like maybe it's not working as well anymore, so maybe I have to go up a little bit in dosage. Right now I'm doing 2.5 pills a day, and so I may go up to 3 pills a day. I haven't decided on that yet. And before that, I did 2 or 3 different stimulants, extended release, immediate release, whatever. But I have a heart condition that causes palpitations and weird stuff. So the stimulants really weren't too good of an option for me. So that's why I'm trying the Clary.
Gotcha. Thank you for sharing. Dr. Plant, incidentally, you know, Sarah just mentioned that she notices her treatment may not be working as well as of recently. And it just sort of made me kind of think, I've heard from other people that in the wintertime their symptoms seem to be worse. And I just wonder if you might have any insight into that with the research that you have been doing, or do you notice that people complain that they are sleepier in the wintertime versus in other seasons of the year?
Well, so in general, a lot of people will complain about being excessively sleepy, more so in the winter than the summer. Some of that may have to do with components of, for example, seasonal affective disorder, which is a typical mood disorder where people, again, have sort of low mood as well as some what we call neurovegetative symptoms, things like poor concentration, fatigue, lethargy, more so in the fall and winter. I don't know of any research around whether or not people with idiopathic hypersomnia specifically have seasonal patterns to their illness. I mean, one of the things that's really challenging about idiopathic hypersomnia itself is that for a lot of people, we don't know what the root cause of the disorder is. So, and in many ways, it's very poorly studied compared to most other sleep disorders. So that's one of the really nice things about, I think, this particular foundation, is it sort of gives people a voice and a chance to sort of coalesce around, you know, similar symptoms, so we can learn from patients. But, you know, I don't know if people get sleepier in the winter, but it's certainly possible. And if a patient told me that, I would certainly, you know, take it at face value. But I don't know what might be causing that specifically.
Okay, thank you. It looks like we have a question from one of our audience members. So let me try to, Bobby, can you, do you see the question?
Sure, just a second. Is it showing?
I can pull it up. Let's see. Let me try. Can we see that?
There we go.
Okay. So this question is from Kate Murray, and her question is, how many of the participants were diagnosed with ADD or ADHD as children? Very interesting question. Thank you, Kate, for your question. So quick poll. Alex and Jenni and Sarah, were any or all of you diagnosed with ADD or ADHD?
I was not, neither.
Okay. Jenni?
Yeah, I was. I was diagnosed when I was 4. Looking back, it wasn't a valid diagnosis, and later on, they're like, "This isn't right." But yeah, I was diagnosed at 4 years old with ADD, and then later ADHD.
Sarah?
No, I haven't had anything like that diagnosis.
Jenni, I wonder if in hindsight it was just because you were sleepy, so you couldn't focus.
Honestly, yes, most likely, because the same thing happens with my dad and my sister. Like, people have thought that they had ADD. My dad, ironically enough, when he had a sleep study done, they had a problem because he kept falling asleep before they could finish hooking up all the electrodes and all of like the all the stuff. So
I think that
yeah.
proves it.
Yeah. Both my sister and my dad are also have been misdiagnosed with it and are definitely excessively sleepy.
Dr. Plant, I just wanted to come back to you for a moment. Can you talk to us a little bit about the correlation between depression and idiopathic hypersomnia, if there is one? Does one cause the other? Do you notice a correlation at all in your research?
Sure. Well, so that's a really great question. I think one of the fundamental things to keep in mind is both with depression and with idiopathic hypersomnia, we really don't know what's going on in the brain that's causing either of these problems. What we do know, though, is that people with idiopathic hypersomnia, when you sort of look at them as a group, they tend to have higher rates of depressive symptoms than the general population. So we don't know exactly how many it is, but a good ballpark estimate would be about 15 to 25% of people who have idiopathic hypersomnia are going to have depressive symptoms. Now, one of the big questions is that really the same as depression? So is it the same neurobiologic thing that's happening? Or is it the fact that people with idiopathic hypersomnia often have a lot of other symptoms that sort of get mischaracterized as depression? So it's very common for people with idiopathic hypersomnia not only to be sleepy, but to be fatigued, to have poor concentration, all of these kinds of things, which can lead to, you know, problems with clarifying the diagnosis. And when I hear that a lot of people were diagnosed with attention deficit disorder, for example, that's another disorder that's often sort of misdiagnosed, and sort of a general sleep disorder is missed. So we see that quite frequently. A lot of times people with both idiopathic hypersomnia and also narcolepsy, which again is another disorder of central nervous system hypersomnia, are misdiagnosed often for long periods of time as being depressed or having depression, and it really takes a while until someone sort of puts 2 and 2 together and sort of sends people to either the appropriate doctor or gets the appropriate test to sort of get treatment on the right path.
Thank you. So Alex and Kate and Sarah, I just want to open it up to you. Has any doctor told you that maybe you're just depressed before you got your final diagnosis of idiopathic hypersomnia? Do you find that some of the things that Dr. Planty was saying are true for your experience? So Alex, I'll start with you.
I did have a school nurse try to diagnose me with depression. I'm not sure how qualified she was to do that, but she did, and she suggested that it might be, and she wasn't totally off base, I suppose. I've had relatives ask if that might be what it is, and for a while I wondered if it was. I had like this internal debate: am I depressed? I didn't think I was, and so that is, yes, I have people have tried to suggest that might be what I have.
And do you think it's just because you're tired and lethargic some of the time, or?
I think it's because it's something that people don't understand unless they have it. Everyone gets sleepy. If someone doesn't go to bed till 3 a.m. and they have a class at 8, they're going to be sleepy. And so it's hard to, I think, wrap your head around something that's where you're like that and it's uncontrollable. So it does seem to people like it might be that I'm lazy, or in this case, depressed. I don't feel like getting up, or don't feel like living my life, and that's not it.
Jenni, have you, in your experience, let me put you in the big screen here.
Oh.
So tell us about your experience with this.
So ironically enough, I spent like most of my childhood, adolescence, being treated for mental health diagnoses. Especially like serious mental illnesses in terms of like bipolar, and other things like that. And it turns out I don't have bipolar, but no one's ever accused me of being depressed. I think usually the reaction I get is that I'm just really lazy. And I think like the only way I can describe the way it feels is it's similar to like when I go under general anesthesia. Like there's that overwhelming like drugged feeling where you're just like you get like pulled under is the way that I experience it. And I think the reason that a lot of people misdiagnose it as either depression or bipolar or some other mental illness, especially depression, is that like if you look at a commercial on TV, they show someone with depression is sleeping a lot. Most people have never heard of hypersomnia. Most people aren't familiar with any kind of sleep disorder whatsoever. So I think people are trying to be helpful, and that's the first thing that comes to their mind.
And
we have another.
Go ahead.
Sorry, I was saying we have another comment.
Oh, great. Do you want to pull that up, Bobby, or do you want me to pull it?
Let's see if I can get it up there. Oh, okay. Is that showing?
I think you click the eyeball.
Right. Let's see. I don't know why it's not working.
Okay, let's see if I can pull it up.
There you go.
Did that work?
Oh, no.
Can you see that?
I can see it.
It shows up on mine.
Okay.
And no, I've never been concussed.
No, I've never, to my knowledge, never had that problem.
So Mary's question is that Jenni mentioned having had concussions, so she's curious if Sarah and Alex have also had them, and they have both said no. Thank you for your question, Mary. It's interesting that she asked that question because in talking to many people with idiopathic hypersomnia, I do find that there are a lot of people that have had concussions or some type of head injury in their past, and then later on down the line, idiopathic hypersomnia develops. So that's just something interesting in our non-scientific, totally anecdotal poll.
Makes me wonder what other causes there might be for hypersomnia, whether or not it's all genetic or if there are external things that could cause it, like a concussion.
So let's talk about, I know, Jenni, you're in college, and Alex, you are in high school. I just wanted to quickly take a few minutes to talk about any school accommodations. So Alex, did you talk with your teachers? Were you on a 504 plan or an IEP? Did you have official accommodations offered to you from your school system?
I go to a Catholic school, so they have their own version of that, and it was offered to me. And I guess the first thing I want to say is that I definitely recommend if there's anyone watching that is in high school or college, definitely tell your teachers about this. One of my biggest concerns originally was that they would, or I was, like we said earlier, lazy, or I was just not getting enough sleep, or I just, like I said, I didn't care about their class, and that really worried me because I wanted to, I think I did care, and I wanted to do well in the classes, certainly. And I also, at the same time, didn't want to be a special case. I didn't want to have all these accommodations. I didn't want to have to roll into bed to class to take calculus and have a little bed in the corner for me, which someone actually suggested. So I said, no. So definitely going to tell your teachers is a great thing, and they're all, at least in my case, all very understanding. In fact, I met the first person I've ever met with hypersomnia. One of my teachers, funny enough, ended up also having hypersomnia.
Oh, wow.
I know, it was wonderful. So that was actually one of my first sources of support in that way. And so she's always been helpful and always asked me how I'm doing, and it's great to talk about it in person. And this was, again, before I even joined the Facebook group or any of that, someone who also goes through that. Now, with my counselor, I did go talk to her, and she did have a form, and they were very accommodating with regard to extended time on tests, extended deadlines, and things like that. One thing I do is I will, and this is definitely more of a discreet thing, I don't, like I said, it's not something I want everyone to know about. I don't advertise the fact that I have hypersomnia, but one thing I do is I'll just, if I'm really about to fall out, I'll get up and go try to walk around. I'll do the school 500. I go take a lap. and I'll go walk around, and or I bring water with me to class as a way to cope with that. So little things like that can help. And if I'm really having a tough time, then I've also spoken to the nurse, and she's aware of the condition, and so I'll go and take a quick power nap in the clinic and come back. So that's.
How about you? Have you noticed? Have you asked for any special accommodations in your college? Do they have 504 accommodations that they extend to you?
Unfortunately, especially because my case isn't so much like occasionally I'll fall asleep in the middle of something, but for the most part, it's an issue of like, I got the nickname Sleeping Beauty quite a few times because once I'm asleep, I will sleep. I'll sleep forever if you let me. So one of the problems is that in universities, the only thing that they're required to do is make ADA, American Disability Act accommodations. In terms of my issue is that sometimes I won't show up to class because I've been asleep for like 2 days and I missed it. But the attendance policy is set by each individual professor, and if they don't want to make accommodations, they don't have to. Because I also have a genetic physical condition that's more, I wouldn't say people understand it more, but people take it a little bit more seriously in my experience. They're more accommodating with that, but even then, some professors will just be like, oh, I'm going to fail for participation because you missed 2 classes because of XYZ. So it's really difficult when it comes to university policies, and that's all universities in the United States. They just have to do the ADA requirements, unfortunately.
And I've yet to seek information on this with Elon in North Carolina. So it's a bridge I'll have to cross when I get there.
I'm registered with my university's Disability Resource Center. The problem is that the only accommodations they can ask for are note taker, transportation, which I take them up on, and extra test taking time. But none of that really helps if it's a matter of attendance. So
Sarah, I saw that you typed something in the chat about strategies for working. So do you want to share some of those with us?
Well, my main one, and I actually did this before I was diagnosed, but I have a standing desk at work, so when I'm in the office, I stand up, and it's hard to sleep when you're standing up. When I'm at home, I just put my turn my computer on really loud so that if I get an email in, it beeps. And then I just lay down on the floor next to my computer and I just go to sleep. But yeah, when I'm at work, I have a standing desk and I really like it.
So let's talk about symptoms, signs and symptoms. The 2 main ones that I've heard people talk about before, besides excessive sleepiness, I've heard the term brain fog, and I've heard the term sleep drunkenness. So do any or all of you experience those, and can you tell us a little bit about what that's like for you? Jenny, do you want to chime in? You seem to have that with you.
Yeah, another one is I get really aggressive. my roommate is sitting next to me right now and making very strange faces. I get very aggressive and angry if you wake me up, but I don't remember any of it, so it'll happen in my sleep. I'll say mean things, basically anything to get more sleep. But I'll do things and I'm still not 100% awake. Sometimes it will take quite a while, so I can't really, if you have a conversation with me, I won't remember it or anything like that. And I just kind of it just feels like I'm half asleep still.
Sarah or Alex?
Yeah, for me, definitely the sleep drunkenness and the fog. It's sometimes I'm floating through my day. Another thing I do is I'll lose words, and that's very upsetting to me. I will just, it's I'll be on autopilot, and I hear the words come out of my mouth, and they don't make sense. Or I'll skip words in my sentences, or I'll the wrong form of the word. It's just things like that. or I can't say something. I try to make my mouth say something. It's just not coming together.
Sarah, I saw you chuckle when he mentioned that. Have you experienced that?
Well, yeah, that's one of my big problems. My husband constantly makes fun of me because he'll say, it's a noun, use it. And I was going to ask you, Alex, is it usually a noun? I don't know. For me, it's like I will say a sentence in a heartbeat. It'll sound like, did you go to that place where we were yesterday when we lost that thing and talked to that person who had that other thing and told us where to go when we went there? You know, that, and he's like, what? So yeah, that's my thing.
Oh, for me, it's almost sometimes I slur words. Oh, we need to get in the car with the car, you know, things like that. And I was hearing myself, and I'm like, that's not really what I sound like, is it? Yeah. So, or I'll forget what something's called. I feel like, oh my gosh, I've got Alzheimer's or something. And and I'm 18 years old. So I definitely understand.
So I just wanted to switch gears for a minute, Dr. Plant, and I wondered if you could just talk with us very, very briefly without giving away the farm about your research. I know that you're going to be presenting at the Hypersomnia Foundation conference that's coming up in July, and I wonder if you might be willing to give us just a tiny sneak peek of the things that you might be talking about. So if there are people out there that are interested in learning more, they can think about attending our conference and coming to your session.
Sure, I'd be glad to. So really what my primary research, or at least the research in my lab right now, is focusing on is looking at hypersomnolence disorder and depression. So what we're really interested in is sort of trying to, basically come up with better ways to identify sleepiness in this particular group of people. So as I had mentioned before, it's often very difficult sometimes to tease apart if someone has idiopathic hypersomnia and depression occurring at the same time, or if they have depression but they have excessive sleepiness that's separate from idiopathic hypersomnia. One of the things we know is that when we do the multiple sleep latency test in people who have depression but not idiopathic hypersomnia, most of the time people with depression are not going to have abnormally short sleep latencies. However, the reality of that is actually very, very unclear. So about a third of people with depression will have a short sleep latency when you sort of look at all the data that's out there. So the MSLT, or the multiple sleep latency test, which is a test that we use very commonly in sleep medicine, everyone here on the panel has had one to try to clarify the diagnosis, really doesn't sort of capture all the facets of hypersomnia that are there. It's really measuring just the ability to fall asleep in a relatively artificial situation. And so some people are quite successful at doing that, but some people who are very symptomatic are not able to do that. So in depression, that's the kind of thing that we can see. So one of the things that we do here at the University of Wisconsin is we're sort of a center of excellence using something called high-density EEG, which people had discussed before, all the different things that go into a sleep study. One of those is EEG, which stands for electroencephalography, which is basically a fancy way of saying we measure brain waves. Most of the time when people get a sleep study, we just have about 6 channels or so. So they're very spaced out on the scalp, so we don't really know what's going on in a particular part of the brain at a particular time. What our lab does is we actually use 256 channel caps. What that allows us to do is really get a good look at what people's brain activity looks like sort of all over their brain, and allows us to sort of look at specific things that might be going on in certain parts of the brain. So what we're studying right now is, again, high-density EEG during both sleep and waking in patients who are both depressed and hypersomnolent, and we're trying to see if there are certain markers in their EEG that may suggest either why they're sleepy and also be a marker of objective sleepiness in this particular population.
Wow, that is absolutely fascinating, and I can't wait to hear more about that at the conference. Your session is definitely one that I'm going to be attending. Appreciate you sharing that with us.
Great.
I have a question for Dr. Plant, if that's okay.
Sure.
Sarah?
I'm kind of curious, before we opened the live session up earlier, we were talking about the fact that some of us are depressed slightly because we're sleeping all the time and we're missing out on half our life, and we feel miserable. And so, yes, it causes a little bit of depression. And if I were chipper and happy about this, then I would think there was something wrong. So how do you separate that?
I mean, that's the million-dollar question, right? So there's the particular patient population that I'm very interested in are people sort of who have those exact same problems. How do you really tease it apart? Because right now, I think most people who practice sleep medicine are going to be very reliant on using the multiple sleep latency test to sort of try to distinguish whether people have idiopathic hypersomnia or depression associated with a mood disorder. The reality, though, is that multiple sleep latency tests, like we talked about before, there's lots of people with idiopathic hypersomnia who may have not abnormal results. So it creates this paradox, right, of trying to understand, like, well, what is really going on with this particular person? And it's almost impossible to know. I mean, really what we need to fundamentally get at is understanding the cause of these particular problems. And the reality is a lot of people with idiopathic hypersomnia are going to have different types of things probably driving their sleepiness and their excessive total sleep time, because the brain is an incredibly complicated organ, right? And so there may be some people who have, there's a very strong hypothesis that people sort of talked about indirectly here of GABA-related hypersomnia, where there's potentially something in their cerebrospinal fluid that's sort of causing people to feel more sedated, because GABA is the primary inhibitory neurotransmitter. But there's probably other people who don't have that, who still have idiopathic hypersomnia, and we don't know why. So, really what we need to do is try to understand what's causing hypersomnia across a lot of different patient groups, because that'll help us, I think, understand the cause of it so we can sort of build better treatments. Because one of the things people have talked a lot about is that they've had difficulty finding an effective treatment for them.
It's so interesting to me that you bring up the GABA issue, because in my limited anecdotal experience, that's definitely non-scientific. I have talked with a lot of people with idiopathic hypersomnia for whom flumazenol is working well, and I've also talked with a lot of people for whom flumazenol is not working or hasn't worked at all for them. And so that's very interesting, that there could be multiple things going on, and that's exactly why we feel like the Hypersomnia Foundation is so very important, because we need more money and more funding into the research so that we can look into the causes and potential treatments to help people out there. Let's talk about it. We just have, believe it or not, a few short minutes remaining on the show, everybody. So why don't we talk about some tips that we can offer out there to people who are facing the same road, same path that you guys have gone down. And so, Dr. Planny, I'm going to ask you for a tip at the end as well. So, Alex, maybe we can start with you. If you were talking to yourself at the very beginning of your journey, or somebody like you, what might be a tip that you would offer to yourself to help you in your path?
I would definitely tell myself that there are other people that have this, that are dealing with this every day. When I was first diagnosed, I thought, oh my gosh, I feel like I'm the only one in the whole world with this. That people aren't going to get this. I'm the only one. There are people that get this. There are lots of people that get this, and there's a great community of people that do. And just to know that it's not you. It's something you can't control. You're not just a lazy person. You're a capable person of doing incredible things with a little curveball in your brain. It makes it a little bit harder to do those things, but it's not you, and you can't blame yourself for that.
Okay, I see that we have a question from an audience member that has popped up, so I'll come right back to that in just a minute. But Jenny, do you have a tip that you could offer to anybody out there that might be facing a similar path as you have faced, and something that they might find helpful?
I think the biggest one is ask for help. I've tried to do it on my own, and I can't. I'd say ask for help, and also I highly recommend the sonic alert alarm clocks for people who are deaf and hard of hearing that vibrates your bed. I've been trying to come up with some different types of alarm clocks that would work and pour water on me or shove me out of the bed. I haven't really got anything solid yet. But I would definitely say, get a sonic alert alarm clock and get people to help you.
Okay, so just another quick anecdotal, non-scientific poll. How many of you use more than one alarm clock?
Oh, I use so many.
Jenni does.
See, I have one, but it makes two different sounds, and I set it across the room, so I'm forced to get out of bed to go walk to it. And sometimes I don't do that, and I sleep through it, and the sound becomes part of my dream. Like I'll be in a fire station, and the alarm's going off, and it makes perfect sense for the alarm to going off.
I've slept through earthquakes and fire alarms. It's a problem.
Sarah, how many alarm clocks do you use?
I have one alarm clock. It goes off one time, and I get out of bed. And then 2 hours later, I want to take a nap, and 2 hours after that, I want to take a nap, and then on throughout the day.
And then do you have a tip to offer somebody who might be facing the same path that you've taken?
Yeah, when somebody says it's all in your head, it may actually be all in your head. That's where your brain and your spinal fluid is. All kinds of stuff is in your head. So yeah, don't believe them that it's mental. It's you know, it's real. But no, I've had an easy path. I've just been very lucky in my diagnosis and my support and stuff. Yeah.
Dr. Plant, I wonder if you have maybe a coping tip or any kind of tip for somebody out there who might be facing a path and scratching their head and wondering if they have idiopathic hypersomnia.
Yeah, I mean, I think that what some of the great points have been raised by everyone on the panel is the need to sort of advocate for yourself, to try to find sort of clinicians who have some familiarity with these particular problems, because a lot of times people, you know, it's the problem. If you don't think of it as a potential problem, you're never going to be able to diagnose it. So I do think that trying to find someone who can sort of point you in the right direction, do the right testing, is vital. And then once you find that person, I personally think if I was going to give people one tip, is to keep very careful track of how they respond to treatment. So using things like sleep logs and keeping track of how people have done on medications is really, really helpful in the long term, because really, at this point in time, we're still largely at trial and error medicine with this, where we give people medication and then we see how they respond to it. So the sort of more detailed information you can have for yourself, I think the better you're going to know how you respond.
And hopefully shows like this, you know, that are out there on the internet for people to find will be helpful as well. So thank you very much. Dr. Plant, I wanted to pull up a question from an audience member that we have here. So I wonder if you'd be willing to read this question out loud and possibly answer it if you have any insight into the answer.
So have you found many people with dysautonomia who also have idiopathic hypersomnia? So I'm assuming that would be like a dysfunctional autonomic nervous system. And then can I wager a guess at would there be a connection? So in my personal experience, the answer is no. I haven't had people who have had those specific comorbidities at the same time, but I wouldn't be surprised if there were people who had, you know, similar overlaps. So the autonomic nervous system being, people are familiar with the fight or flight mechanism. So it's a part of it's the sympathetic and parasympathetic nervous systems that control a lot of the unconscious actions in our body. So it wouldn't be surprising if people have overlapping problems between sleep and dysautonomia, but it's not something that I've seen enough of or can wager what the connection would be.
And if I could say one quick thing, you saying that just reminded me of this. Several years ago, I had a condition in my hand, and it was my hand locked up kind of like that, and it was the most extreme pain I've ever felt. I was told that it was reflexive sympathetic, oh goodness, dystrophy.
Mm-hmm.
And so I wonder, I don't know if that's connected to what you were just saying or not, but definitely still nervous system related.
It could be. Did that problem go away for you after a while? It
did, yes. Yeah.
I
think they said it was under the umbrella of complex regional pain syndrome.
Mm-hmm.
So
again, I'm not sure if there's enough data to really know conclusively if there is a connection, but that's one of the great things about these kinds of forums, because then people can sort of start talking about it. And really what we need to do is get a large group of people with idiopathic hypersomnia together and try to understand, you know, what other symptoms go along with this, what other disorders go along with this, because that's really the only way that we can study it or hope to be able to study and understand these kinds of connections.
And that's a great segue into mentioning the upcoming conference for the Hypersomnia Foundation. It's going to be in Atlanta, Georgia on July 17th and 18th, 2015 at the Emory Conference Center. And for more information or to register to attend the conference, you can visit our website at www.hypersomniafoundation.org. And, you know, it's a great opportunity for people with idiopathic hypersomnia to come together. It's extremely powerful for, you know, to be in the same room with a whole bunch of people that are just like you. And the talking and the sharing and the camaraderie that happens during the conference is just amazing and powerful. And it's really helpful for physicians and scientists, as well as for the community, for people with hypersomnia, as well as their supporters. You know, supporters find great support in attending the conference as well. So as it turns out, that is all the time that we have for today. So I want to thank our guest panel members. Thank you, Alex and Dr. Plant and Jenny and Sarah for joining us today. And a very special thank you to Fabi for being our wonderful technical producer on such short notice on the show today. Thank you very much.
Thank
And
you.
I want to thank our live audience members for posing questions to our guest panel members. Thank you so much for participating. And I want to invite you all back to our next episode, which is going to air on Friday, March 13th, 2015 at 8 p.m. Eastern Standard Time. The topic of our next show is going to be all about narcolepsy and narcolepsy advocacy. And our guest panel members are going to include representatives from Narcolepsy Network and Wake Up Narcolepsy and Project Sleep, as well as the Stanford Medicine Center for Narcolepsy. So we're going to have a really powerful guest panel on our next show as well. So I invite you all to come back. And on that note, I just want to remind everyone that we are not going to take it lying down, and we will see you next time. Thanks for joining us.
Thank you.